Good evening, all of you. And I thank Dr. Vijay Patil and Dr. Akshay Katte for inviting me here. Today, I am tasked to discuss the selection of first-line therapy for ROS1 rearranged NSCLC. So I divided my talk into these subheads of historical perspective, pathobiology, and clinical features. Testing, I will, as already it was discussed by Dr. Sunil. So we know that nearly 3 million deaths occur annually across the globe due to lung cancer, and NSCLC account for 80%, and ROS1 fusions account for 1 to 2% of NSCLC. When we see the incidence across various parts of the globe, the incidence is nearly 1 to 2%. In India, it is slightly higher. We saw the Rajiv Gandhi data of 2.8%. So when we see the ROS, it is a receptor tyrosine kinase, a sarcoma oncogenic factor. Like many other targets, it was initially described in the glioblastoma cell lines and later in the GBM tumor tissue. And the initial fusion that was discovered was the FIG-ROS. So 1981, it was the initial cDNA isolated, followed by ROS1 fusion NSCLC only 30 years later detected in the NSCLC. So this is a TISA question that was usually asked. So what are the cancers that with the ROS1 fusions? Cholangio cancer, ovarian cancer, IMFT, and acanthus melanoma. So this is the timeline of ROS1 targeted therapies. We have seen the 1987 timeline, and then initially crizotinib, followed by ceritinib, and then lorlatinib. All these were evaluated in the, and then came the approval of the entrectinib. When we see the pathobiology, ROS1, it is located on chromosome 6q22. And the most common fusion partner with the ROS is CD74. There are so many partners, but the most common is CD74, just like EML4 for the ALK. It is called as, it is referred to as orphan receptor. Why it is called orphan receptor? Because the ligand is not known and its physiological function is not known in adult. It's the main function of ROS is known during the embryogenesis and it becomes silent in the adult. However, it becomes re-expressed during the oncogenesis like many other genes. And when it becomes activated, the pathway that gets activated is RAS, RAF, MACAC pathway. So this ROS and ALK, it gives a distracting message that it may be membranous receptors. No, they are cytoplasmic receptors. Both ALK and ROS are the cytoplasmically expressed proteins. So the type of mutation we have seen that CD74 fusion is most common, and it seems to have more brain metastasis at the baseline compared to other fusion partners. And the co-mutation matters, just like our colleague during the training, during the residency matters, the co-mutation do matter. Initially, we know that only the mutation and the targeted therapy. After that, we know that all the mutations are not equal, so the co-mutation matters. If there is TP53 mutation, it will have shorter PFS with the same TKI. When we see the clinical features of ROS positive NSCLC, it seems that majority of the patients, more than 60% in of all the trials, they are the non-smokers. Majority of them are females and adenocarcinoma histology in more than 90% of the cases. Testing was exclusively described by Dr. Sunil, so I am skipping this. But as a clinician, my take-home point is never start treatment with IHC positive ROS. All IHC positive reports to be confirmed by FISH. Only then we have to start the treatment, because no trials have used IHC as the screening, as a method of detection of ROS in the clinical trials. So coming to the ALK inhibitors, as ROS inhibitors, why it was done in the initially? Because there is more than 60% homology between the tyrosine kinase domain of the ALK and ROS. And so there were the preclinical trials done and seen that ALK inhibitors do act against the ROS tyrosine kinase also. So there are 4 drugs that are currently active against the ROS rearranged NSCLC: crizotinib, ceritinib, entrectinib, and lorlatinib. The good thing is that any of the drugs at least gives a response rate of 60%, and ceritinib, lorlatinib, entrectinib in those orders have the highest amount of intracranial activity. And one more drug is in the trial, that is repotrectinib. So this is a 1 year ago NCCN guidelines showing crizotinib and entrectinib. Now ceritinib is also included in the first line guidelines of ROS positive NSCLC. The initial approval of crizotinib was done in 2012, nearly 5 years after the discovery of ROS1 in the NSCLC cell line. And entrectinib was done very recently in 2019. Coming to crizotinib, we know that it is a multi-kinase inhibitor against ALK, ROS, as well as MET. The profile is a trial of crizotinib predominantly for all patients. However, there is an extension cohort to study of efficacy of crizotinib in the ROS1 mutated patient. It is a phase 1 small study, single-arm, multi-centered study involving 53 patients. I just want to focus on important points. In this trial, brain metastases were allowed, and most of them are in good performance status. However, ECOG-2 patients can be enrolled with the discussion of the investigator and sponsor mutual agreement. So they have looked at the response rate, PFS, and overall survival, and the median PFS is 19.3 months. Looks very good. Nearly 50% of patients, they are alive after 4 years also. And median OS is crossing 4 years and is nearly 51.4 months, which is really encouraging. Coming to the safety summary, there are no grade 4 and grade 5 side effects with the crizotinib in these set of patients. However, there are some deaths regarding to the trial, but there is no treatment related deaths. So any death that occurs during the trial is included in the trial, so that but regarding the crizotinib toxicity, there are no deaths. So these are the side effects that occur in more than 10% of treated patients, which include vision disorders. The vision disorders may be as small as photopsia of floaters, and as severe as retinal detachment, retinal derangement, and severe vision loss. Followed by nausea, edema, diarrhea. These are all the GI side effects. We know that there are lab abnormalities, elevated transaminitis, which requires the dose modification as discussed by the previous speakers. However, whenever we are discussing any costly treatment or any newer treatment, it is always good to refer to the package insert. So what does the package insert of crizotinib says? It says there are 3 important organs that may be affected, that is GI system, including the liver and GI side effects, and pulmonary toxicity, interstitial lung disease, and cardiac system, which includes QT prolongation and bradycardia. And if the bradycardia is severe, it may require discontinuation of the crizotinib as well. So this is the summary. Median PFS 19.3 months is the takeaway from this trial. So this is the crizotinib trial from the profile study. However, there are 2 important other trials which have looked at the PFS of crizotinib in the Asian subset as well as the European subset. So what are the results in the Asian subset? So we know that Asian population is different compared to the Western population as far as lung cancer is concerned. Within the Asians, Japanese, they have separate trials, separate results as far as the targeted therapies are concerned. And this is the study which included predominantly Chinese and Japanese population. And the primary endpoint is overall response rate. We can see here the response rate is 71%. And I want to concentrate on this point of population. Nearly more than 40% they are smokers. So when we see a smoker, we should not be nihilistic to test them for the targeted therapies. So median PFS is 15.9 months. So similarly, another study conducted in the European population, UCROS study. Here, the number of population enrolled are very less, 30 patients. Median PFS is nearly 20 months. So this is the co-mutation activity that was analyzed here, present in ASCO 2022. So if a patient is, if we have done the NGS and the patient is P53 mutated, they have shorter PFS. We can see here the PFS is 7 months compared to P53 unmutated, which is 24 months, nearly 3 times the difference. And similar way with the patient having CNS mets, they have poor PFS of 9 months compared to 20 months without CNS mets. So a patient with CNS mets and imaging and P53 mutation and NGS, they are the worst subset. They will have the least PFS. Coming to entrectinib, why entrectinib is important? Because 36% of patients with ROS ROS rearrangement, they have the brain mets, and when we treat with crizotinib alone, more than 50% of patients develop the brain mets. And we know that entrectinib acts against all ROS as well as MET. Why entrectinib is approved is because based upon the data from the combined analysis of 3 trials of ALCA trial as well as Star Trek 1 and 2. So what was the result? Almost all Asian, European, and Western population were included. Majority of the patients were non-smokers. However, more than 40% are still smokers. And the most important fusion partner that was detected is CD74. And they were the CNS mets in half of the patient nearly. So two important points to note from the entrectinib combined analysis is the overall response is 77%. Intracranial activity is seen in more than half of the patients. And some of them have complete clinical response in the brain also. So this is the waterfall curve of the intracranial activity of entrectinib. What are the common side effects? Change in taste, dysgeusia, dizziness, constipation. Some patient might have diarrhea. But what does the package insert says? Just like we do echo before adriamycin, before starting entrectinib, we need to do 2D echo. And sometimes it may cause severe myocarditis also. And any drug which is acting in a CNS, like lorlatinib, do have CNS side effects also. And so the entrectinib also have cognitive impairment and other similar side effects. Certinib also has been shown to have some amount of intracranial activity. The response rates vary anywhere between 60 to 90%. Not going into the details. Coming to lorlatinib, it is not approved in the first line or ROS1 patients, but there is like the ALK resistance, ROS1 G2032R is the known mutation after treatment with the TKIs in this subset of population. So there is a subset with 12 number of patients with TKI naive as well as crizotinib exposure who are being treated with lorlatinib. And it was seen that even in TKI patients, the PFS is better and it is more than 20 months. So coming to the drugs approved for ROS1 positive NSCLC, FDA has approved crizotinib, entrectinib. EMA has approved crizotinib, entrectinib. Now NCCN has adopted certinib also in the first line of ROS1 positive NSCLC. This is the summary. When we see the extreme right column, we need to see that they have done RT-PCR, FISH, and NGS, but none of the trials have included even IHC as a screening tool also. So this is the main takeaway from this slide. This is a recent NCCN guideline showing certinib, crizotinib, and entrectinib. However, there will be certain situations where we cannot have hands-on crizotinib also for some of the set of the patients, particularly in a setting where I work. I see literally very poor patients, and we do not have much access to the trial due to logistics and the terrain we live on in SM. So it seems that chemotherapy might be an option in some of the patients. For two of my patients who are having ROS, chemotherapy is going on. It seems that pemetrexed is a reasonable option compared to the other subsets. The reason explained is that ROS1 positive NSCLCs, they have lower expression of thymidylate synthase compared to the other types of other subsets. So pemetrexed based regimens, when there is no option of targeted therapy, seems to be a reasonable option. So with this, I conclude my talk. Thank you so much. This is our Tejpur Cancer Center. It was inaugurated on 28th April, this April. And there are so many challenges that we face at the periphery. At the same time, it is also satisfying. Even we get easier for all ROS by individual mutation analysis and treat them, it gives a lot of satisfaction. And thank you for inviting me from Assam to here. Thank you so much.